Hello everyone, I am Dr. Subhas Taylor, a radiologist, Subhas Ultrasound Imaging Center, Bhilwara, Rajasthan. My field of interest is ultrasound, and today I am going to discuss ultrasound features of benign testicular cysts. We know intratesticular cystic lesions are clinically palpable or non-palpable. They can be tender, non-tender, acute or chronic in onset, or can be incidentally detected on ultrasound. High resolution color Doppler ultrasound is modality of choice for evaluation of various scrotal cysts. Most of the intertesticular cystic lesions are benign and can be identified by their anatomic locations. Diagnosis of these cysts will avoid unnecessary surgery. This presentation includes ultrasound characterization of various benign intratesticular cysts. When there is fluid collection in the scrotal sac, we can even make 3D reconstruction of scrotal contents, as we can see in these two images beautifully. Spermatic cord, appendix of the testes, epididymis, and testicular outline in particular. Now coming to sonoanatomy of the testes is thoroughly examined with the help of high resolution transducer thoroughly in entirety from craniocaudal approach in longitudinal as well as in short axis planes. It is well defined ovoid structure with homogenic medium level echoes. It is surrounded by a echogenic line. Here we can see by red arrows is basically a capsule of the testes which is formed by tunica albuginea and visceral tunica vaginalis layer. This is another zoom image of the scrotal sac showing well-defined, compactly arranged two echogenic layers of tunica albuginea and tunica vaginalis. And when there is fluid collection in the scrotal sac, we can see parietal reflection of tunica vaginalis also, as we can see by this blue arrow. These are two different images of transverse and longitudinal scans of testes showing an echogenic structure eccentrically located on posterolateral aspect is mediastinum of the testes, which is seen as echogenic structure. And another important structure posterolateral to testes is epididymis, which has head, body and tail parts, and ecotexture of epididymis is almost equals to testes. And on longitudinal plane, we can see head of the epididymis on abutting the upper wall of the testes in most of the time. Benign testicular cysts are commonly seen are tunica albuginea cyst, simple testicular cyst, epidermoid cyst, ectasia or cystic transformation of Rayet testis, intratesticular spermatoceles, intratesticular varicoceles, abscess, segmental infarcts, or post-traumatic hematomas. Now coming to tunica albuginea cyst. This presents as a small, palpable, non-tender mass, usually affecting elderly males between 40 to 60 years of age. It is commonly seen at upper lateral part of the testis. The cyst is simple, uni or multilocular in appearance, and size ranges between 2 to 5 millimeter. These are testicular scans, longitudinal and transverse images showing a well-defined small unilocular simple cystic lesion at the periphery of the testes in the region of tunica albuginea is classical of tunica albuginea cyst. It is non-vascular structure. It is palpable as it is sitting at the periphery of the testis. Now these are two images of transverse sections of the testes of two different patients. The blue arrow is showing again a small tunica albuginea cyst, and another red arrow is showing a small cystic lesion located at subcapsular location is basically intratesticular cyst. So these are peripherally located cysts but are tunica albuginea and intratesticular cysts. Now simple cyst. Simple cysts are seen mostly in elderly males, and most of the time it is an incidental finding. Simple cysts are seen near mediastinum. They can be single or multiple. Size varies between 2 to 25 millimeter. And these cysts bear all characters of simple cyst, like imperceptible wall, clear or echo-free interior, distal echo enhancement with no internal complexities like internal echo, septi or solid nodule. These cysts, if are small, are non-palpable, and if eccentric or peripherally located in the testes, then they are palpable. These cysts are associated with extratesticular epididymal cysts or spermatoceles. And causes of simple cysts can be trauma, surgical intervention, post-inflammatory, and these cysts require no treatment. Simple testicular cysts are also seen associated with epididymal cysts or spermatoceles. And this is transverse scan of the testes and epididymis showing a small intratesticular cyst seen by red arrow, and another cystic lesion C1 that is shown by red arrow is extratesticular cyst of epididymis. Now coming to another cystic lesion, that is epidermoid cyst. These are uncommon germ cell tumors or cysts. Size varies between 10 to 30 millimeter. These are usually palpable masses and non-tender. Age of affection is variable between 20 to 40 years of age. At ultrasound, these lesions are focal, rounded, target-like lesions with concentric hypo and hyperechoic layers, which gives a typical onion ring appearance. This is zoomed image of the same lesion showing a typical target like an onion ring lesion. Operatively, it was found to be an epidermoid cyst. In this case, we can also see a small ill-defined hypoechoic heterogenic area with punctate foci is another mass-like lesion, was another epidermoid which was basically collapsed. So there were two epidermoids in this case. We can differentiate epidermoid from tumor by its typical target-like or onion ring configuration on ultrasound and negative tumor marker status and avascularity. Now, another important condition is ectasia or cystic transformation of the rete testis. It is diffuse dilatation or cystic changes in the rete of the testis due to obstruction in the efferent ducts. It is a benign condition, usually asymptomatic and seen as incidental finding. It affects elderly males more than 40 to 50 years of age, and it is usually bilateral. At ultrasound, we can see multiple dilated clustered tubules or multicystic mass in the region of mediastinum and associated with epididymal cysts with no internal vascularity. It should be differentiated from cystic neoplasm like teratoma or intratesticular varicoceles. The same case as we have seen previously is showing mediastinal multicystic mass with a large supratesticular epididymal cyst, which is basically a spermatocele, and it is associated with ectasia of the rete testis. Now, these are three different cases and three different testicular scans showing mild, moderate, and gross type of ectasia of the rete testis. Now, intratesticular spermatoceles. These are intraparenchymal cystic lesions seen near the mediastinum and rete testis. These cysts usually communicate with the seminiferous tubules and contains internal echoes and spermatozoa, and that's why they are known as spermatoceles, intratesticular spermatoceles. Mostly spermatoceles are extratesticular and located in the head of the epididymis, but sometimes they can extend within the parenchyma of the testes. They can be unilocular, they can be septate. So this is a transverse scan of the testis showing a well-defined cystic lesion in the region of mediastinum of the testis. Now, there are certain conditions simulating ectasia of the rete. These are testicular teratoma and intratesticular varicoceles. Let us have a look on testicular teratoma. It is a rare tumor in children. It is basically intratesticular complex mass bearing solid and cystic areas, and some internal vascularity can be seen with some calcific foci. And this is color Doppler scan of the same left testis showing some internal vascularity on color Doppler. This is per operative photograph, and biopsy turned out to be teratoma in this case. So this is again a multicystic mass, but it affects entire testis. It is not confined within the area of mediastinum as we can see in the rete testis. This is the differentiating point. And now coming to intratesticular varicoceles. These are basically multiple anechoic, serpiginous or tubular structures of variable size in the testes, particularly in periphery or subcapsular area, and on color Doppler, color flow channels are seen with venous flow pattern. Blood flow augmentation and reversal is also seen on Valsalva maneuver in these channels, and usually intratesticular varicoceles are associated with extratesticular varicoceles. But in some cases, intratesticular varicoceles may be isolated Location is mostly in capsular area and subcapsular area, but these lesions or these channels may also extend within testicular parenchyma up to some extent. Clinically, these patients usually present with testicular swelling and mild orcalgia due to passive congestion. These lesions should be differentiated from pseudoaneurysms, in which pseudoaneurysm we can see yin-yang sign and to and fro flow on color Doppler. Testicular abscess usually secondary to epididymal orchitis, and other causes of abscess include trauma and testicular infarctions. Testicular abscess can be single or multiple. At ultrasound, we can see a well-defined hypoechoic to echo-free or complex cystic mass with slightly thick or shaggy wall with internal echoes and no internal vascularity seen, but we can see slightly increased peripheral vascularity around it. In the typical clinical setting, we can diagnose testicular abscess. This is a small subcapsular testicular abscess. This is 3D reconstruction of the same. Another important entity is intratesticular infarct. Intratesticular infarct is basically focal or segmental infarction of the testes due to occlusion of the segmental vessels. And its causes are epididymal orchitis, trauma or tumor or torsion. At ultrasound, we can see a focal triangular shaped hypoechoic mass extending from periphery towards the center of the testes with no internal vascularity. And rest of the testes show normal flow or increased flow depending upon the underlying condition. It may complicate with necrosis and abscess formation, or it may resolve to a small scar or a small calcific focus. It should be differentiated from tumor, which shows basically internal vascularity and positive tumor markers, whereas for intratesticular infarct usually do not show any internal vascularity and it is devoid of vascularity and in area of infarction. Now, there are two sets of examples I'm going to show you here. First case is post-epididymal orchitis. We can see a thick congested cord and transverse and longitudinal images of the testes showing marked hyperemia. And in testes, we can see a well-defined, large, inhomogenic focal hypoechoic area devoid of vascularity. And this is a zoom image of the testes showing normal vascularity with a large area devoid of vascularity is a segmental infarct with areas of necrosis and breakdown in it. This is another example of torsion. This is transverse image of the scrotal sac showing the testes in transverse plane with adjacent whirlpool sign. And this hypoechoic area, as shown by red arrow, is for segmental infarct. This is the testicular scan of the same testes, longitudinal scan, showing almost average or normal vascularity in the rest of the testes except this focal area, hypoechoic area, which is due to segmental infarct. So this is basically partial torsion with segmental infarct. Now, another condition which we can see cyst is due to post-traumatic hematoma in traumatic settings. And trauma can be blunt, penetrating or crushed. The nature of the testicular injury depends on type and severity of the injury. And injury can be in form of contusion or some testicular disruption or laceration, fracture of the testes and rupture of the testes with associated testicular or extratesticular hematoma or testicular infarction. This is a case having history of blunt trauma, transverse and longitudinal scans of the testes. There is large focal area of hypoechoic inhomogenic echotexture devoid of vascularity. Rest of the testes shows normal vascularity. The tunica was intact in this patient. This is a focal testicular disruption with a large intratesticular hematoma with variable cystic changes due to variable age. The patient was conservatively treated because there was no disruption in the tunica. To conclude, I would like to say benign intratesticular cystic lesions are very well characterized by ultrasound, by their location, by their vascular pattern, and differentiation of these lesions is possible with malignant tumors. Thank you very much for your patience listening.